All right. Thank you all. Thank you very much for having me. I'm very honored to be here. There is a cost, Patricia, to asking someone to speak after Maria, Carol, Afaf, Deb, Hugh, Maddie, and that is that you now must listen to a whole series of disclaimers before I start my talk. This is obviously a very difficult act to follow, and who you've listened to are some of the great thinkers, the great minds in interprofessional education, as you all know. And much of what the committee will be tasked to do is to come up with all of these things you're talking about, innovative, more inclusive, more broad ways of thinking about how we link interprofessional education with practice changes. That, however, was not what I was tasked with. I was tasked with taking a more, if you will, Cochrane-like approach. It is an expanded Cochrane approach, but it is still very much focused on the current methodologies that meet many of the kinds of criteria that my colleagues, particularly physician colleagues, continue to look for before they're willing to invest the resources and the time and the effort to engage in some of these activities. So you're going to really feel the focus draw back, if you will, from the kind of perspectives that you've heard so far towards what really is in the evidence right now from the perspective of what I have spent much of my career as a bench scientist and a clinician, now moving into the educational field more full-time. So I appreciate that. One of the things that I did very quickly was to look through the articles that met the criteria that we used, and it immediately popped out at me. I hadn't thought to do that before, but well over 2/3 of them, the first author, were physicians. And this is the approach that physicians often take to the data. So that's my set of disclaimers. Next, I wanted to recognize my team. The effort to develop this kind of review often takes months and years. We did a very concentrated effort, and I could not have done this without some of my colleagues at the University of Virginia. Lane Phillips and Jessica Malpass are both on the School of Nursing faculty, and I'd also like to acknowledge Dr. John Owen, who's sitting back there, who is a co-director with me for our Center for Interprofessional Research and Education at the University of Virginia. We call the Center for ASARE. I'm going to briefly go over what I was tasked to do, talk about the criteria and rationale we used for study inclusion, a little bit about data analysis, and I am going to fly through these slides. And then I'm going to talk about some of the results that I came up with, discuss the study limitations and challenges, and provide a framework. Another disclaimer now, I will make the disclaimer again. The author's conclusions, the perspectives that I'm providing is based on this data. I want to say up front that I concur with everything that's been said so far in terms of needing a much more mixed methods approach. It was quite an interesting experience for me to move into the School of Nursing, which I did 26 years ago, and just read the doctoral dissertation titles in the elevators and think, my goodness, there's a whole nother world and ways of thinking about things that aren't my area of expertise. So I wanted to make that disclaimer now, and I'll make it again. So the objectives are to look at the best available methods for measuring the impact of IPE on practice and patient outcomes, and talk about some of the methodologic challenges therein. We did a review in pulling abstracts. I can provide you with the search tools that we use to try and locate these abstracts. One of the interesting things is the original search was done using interprofessional education and continuing interprofessional education. We got approximately half as many articles as we got when we added the terms team training, which is the common language used at the post-licensure level, which is also where we focused our efforts. This was not an effort to draw pre-licensure interprofessional education with outcomes. This was all post-licensure. We did a Cochrane-like review and including RCTs, CBAs, and interrupted time series, but we also included some high-quality before and after studies, looking only at healthcare professionals and objectively measured patient and practice outcomes, things like morbidity and mortality, adverse outcomes, very specific quality outcomes. We included subjective information only when the article also included objective outcomes. We also had fairly broad needs in terms for it to be an interprofessional education intervention. We used the definition that Dr. Reeves used in his recent Cochrane review. There had to be more than one health professional, it had to be interactive, and the interprofessional education had to be focused, at least in part, on teamwork skills, not just on developing a new checklist or a new very specific practice behavior. There had to be some effort at actually developing teamwork skills themselves. So we excluded them if there was no concrete educational component, it only involved students, if learning outcomes were the only outcomes measured, and if it was only focused on feelings, beliefs, attitudes, or perceptions. We used an appraisal tool then after locating 47 studies that met those additional criteria, and this appraisal tool was used to review the 47 articles. Those included the new ones that we found as well as those from the Cochrane review. I left out a really important piece here. We were only looking at articles that were published after the most recent Cochrane review, the 2013, completed their review. So this is 2011 through the present day. We also then rated the quality of these studies based on two criteria. One was what we called leveling, whether it was an RCT, quasi-experimental or non-experimental. Our reviewers were independently reviewing all of these articles. I didn't do that. All of these articles, and we had no difficulty at all independently coming up with the same leveling at that regard. The next thing that we did was to try and give a little bit of structured and yet somewhat subjective review of what we also thought about the article in terms of quality. So this included things that were the outcomes that they reported and the conclusions thereof consistent with one another. So you'd find that many articles really went far beyond what their data showed in terms of what they claimed the relevance of their articles were. We talked about, okay, so they tried to have some controlling, but how well did they describe whether there was a control group or not? And that ends up being one of the most difficult and most important things to happen here. I'm going to have to go to my notes now that I don't have slides to keep me on point here, so give me just 1 second to find the right page. We located a few additional new RCTs, 3 RCTs. We didn't find any new controlled before and after studies since the 2011 cutoff for the Cochrane review. We found 1 additional interrupted time study that met our criteria, but we did find 20 before and after studies that had not been previously discussed. Thank you very much. I still don't have it here, but I'll be looking over my shoulder here for a minute. We also, again, said it was post-licensure, but there was a huge range of sample sizes, and the committee was equipped with a table that shows that there was sometimes as few as 20 learners to some of the VA studies. There were thousands of learners involved in the studies. We looked at a whole variety of settings, and we found almost equal numbers of community and academic settings, which I found surprising. However, the majority of those in the community setting were at acute care community settings, if that makes sense to everyone. There weren't a lot of them in primary care settings. Some of them did look at long-term impact, and I found none that looked at community and population health outcomes. Many of the measures that were, oops, sorry, I have the same problem Maddie had here. Some of the patient outcome measures, we certainly looked at some of the traditional ones, morbidity, mortality, length of stay, readmission rates. Others did look at specific care quality goals, adverse events, error reporting and rates. We found surprisingly only 4 studies that looked at patient or family satisfaction, which is something that I'd like to highlight a little bit later. Practice outcomes, there was a lot about clinical decision making, there was much about patient safety and error reporting, care efficiency, the use of checklists, adherence to guidelines. some of the strongest studies, in my opinion, again, included direct observation of teamwork behaviors at the point of care. A couple of them did some with simulation and at the point of care. And only one directly reported costs. In terms of the tools, the clinical database, OR reports, error reporting, observational tools, the standard Press Ganey were used, but there were also many studies that used tools of their own design. Many of them, though, did include the steps that they took to provide validation or inter-rater reliability for those tools. The most commonly used training was crew resource management, followed by team steps, but most of the studies used interprofessional education of in-house design. And I will say that even when they used CRM and team steps, they always had some comment about how they were modified for logistical reasons. They were either shortened, or the simulation was taken out, or some disclaimer, if you will, about which tool they used, and that part was frequently very little information given. They would say something like modified crew resource management, and that would almost be the end of the description. So you can imagine how difficult it would be to compare studies with that kind of information. I was asked to look a little bit at findings. I was focused primarily on methodology, but the statement of task findings of care quality, we found that all of these studies, with the exception of two, really provided some positive information that interprofessional education at post-licensure does impact practice processes. So we saw changes in the use of things like checklists, briefings in the operating room, and other adherence to best practices. Team training, though, was almost always implemented as one part of a more comprehensive approach. So it was virtually impossible in the majority of studies to tease out the educational piece from other stipulated or mandated practice changes. And I have to just highlight one, and I won't quote this one right now, but it said that the best practices in the OR were improved by team training because the nurse was trained not to hand the surgeon the knife until he or she blank. Is that teamwork? I don't know, so it was pretty hard to sort out the educational piece from other changes. Many studies were, again, focused on care processes without reporting patient outcomes, and there were 4 studies that very specifically measured some of our common quality indicators, particularly in the diabetic population, where we saw the best morbidity and mortality figures were in the OR, followed by labor and delivery. In patient safety, we found quite a bit of data on adverse outcomes, and several groups used some quite robust tools that tried to pull together a whole variety of adverse outcomes into a single reportable figure. This has some value in the sense that it provides an additional quantification to their outcomes, but as you can imagine, if you don't report which adverse outcomes very specifically are improved and which are not, once again you're having trouble really deciding whether you've got the best intervention for the most focused kinds of results. And choosing outcome measures was a real challenge for many of these studies. So patterns were difficult to discern. Error rates declined, error reporting increased. We talked about, someone mentioned earlier, and forgive me, I don't remember who mentioned it, but the culture of safety being something that's an emerging thing that's being measured. We saw some of that in several of the studies. I, again, was quite distressed by the lack of data on patient and family satisfaction. Interestingly, only 2 out of the 4 studies that looked at patient satisfaction showed a significant improvement. And I'd like to speak to that a little bit later. I have some strong feelings about that and why that might be true. Costs, there was only 1 study out of the group that directly measured costs. Several measured care efficiencies, inferring that costs would be improved. However, one of the concerns there that was registered in the discussion section, as well as by our own team, was often then that was not correlated with patient outcomes. And whether, as was alluded to earlier, whether efficiency is really a goal that we should be having unless we're looking at patient outcomes is something that I think we also need to consider. The characteristics of the studies from my review of the data that seem to be most correlated with positive patient and practice outcomes were high learner participation rates or, unsurprisingly, self-selection to the intervention group. And I think this is a big challenge. There was only one study that provided a full day out of the OR schedule to allow everyone in the OR to participate. There were no elective operations for a day, and no one was allowed to return to the OR unless they had been through the training. There were a couple where they were incentivized with continuing education credits, but for the most part, it was come if you can, please. And unsurprisingly, again, that provided a very skewed mix of participants. We saw, I in fact called a couple of the first authors on some of these papers and said, you listed physician participation, how many physicians did you have participating? And it was 1 out of 8 different training sessions. 1 of those had a physician in it, and yet the way it was reported was, this is interprofessional, we included physicians, nurses, pharmacists. You see where I'm going with that. The other thing was this combination between teamwork training and task work training. It often wasn't clear. That's a terminology that Dr. Salas has used. It wasn't clear how much was really about teamwork behaviors and how much was just when you go in there, you need to use this checklist in this order. There were many other changes in practice processes that accompanied the interventions. And this actually seemed to be a very powerful way of creating patient change. So one of the things I would suggest the committee needs to examine is what is the value in looking at interprofessional education as a separate intervention from other kinds of teamwork interventions that one might implement at the same time. I would suggest that because teamwork training is expensive and difficult, there is still some value in exploring that as an individual impact, but that if we're moving ahead as quickly as was just suggested by Dr. Barr and as Dr. Brandt mentioned, maybe we don't have time to do that, and maybe we simply need to be looking at what are the most effective ways to combine teamwork training with practice change that will give us the greatest change in patient outcomes in the shortest amount of time. So I throw that out to the committee to consider. Many of them use simulation. Again, some of the previous studies said simulation is not the be-all and end-all, but most of the positive studies here did use simulation and videotaping where people could assess their own skills. Repetition was important, as was regular feedback, and then observation of actual measurable changes in teamwork behaviors before worrying about patient outcomes. So making sure that your teamwork training actually changed how practice was delivered before assuming that your teamwork training was the cause of the change in the outcomes. So those were the positive things. There were a lot of methodologic limitations. Trying to find a control group was a big challenge. Even, as many of you know, within your own institutions, no 2 units are the same, much less 2 different hospitals being the same. Only very large studies, I thought, made a case that they had addressed that. Inadequate control of multiple other simultaneous practice changes. I already discussed my ideas about that. Outcome measure choice, I think, is something the committee needs to grapple with. What is of greatest concern to our patients and to our healthcare systems, but also what are more likely to be amenable to improvements with interprofessional education interventions. How much? How long? We began to see behaviors decaying over time in some of these studies. And I believe strongly that we need to link practice and patient outcomes with the patient experience of care. And it may be that we need new tools on how to measure how teamwork actually changes the patient experience of care. It may be that the lack of significance in some of those studies is that the tools that they were using weren't getting at the kinds of factors that might have been impacted by teamwork. We need to talk more, about who's involved, get clarity if those trained together actually work together. Dr. Salas again talks about ad hoc teams being quite effective, but do we know how many trained individuals on an ad hoc team results in that being effective team. And then the one where I think this group will have the greatest well, I shouldn't say that, one area of great expertise here is really trying to look at standardizing what kinds of interprofessional education interventions that we choose to use. They need to be evidence-based, they need to be competency-based, they need to be in situ. All of those things that we've learned need to be applied to future studies. I do believe strongly after reviewing these that we need to use good observational tools to look to see if there are real changes in practice behaviors before we decide whether the patient outcomes are related to those. And we need to do better business case making for doing this. At least in my world, if we're not measuring costs, we're probably not going to get on anybody's radar screen. So based on the data in here, you've either got to do a large RCT, but I would personally like to make a case for really well done interrupted time series. Those can be done within almost any care setting. If you separate out your interprofessional education from your other interventions, you can look for nuanced changes in the curves of outcomes that you're looking at, and I think they're more feasible for many of us than RCTs. But again, a mixed methods approach I think would be even better. You want to really put a lot of thought into what outcome measures you're going to measure, decide what those are going to be, and report all the results. There was some real concern of selective outcome reporting in some of these. You want to do really robust pre- and post-intervention data collection at multiple points over several years and make sure that the IP intervention is adequately isolated. You want to optimize the interventions, as I mentioned previously, and I think we need to look at how we can incentivize participants to really come together in true interprofessional teams rather than having 9 nurses, 2 pharmacists, 8 surgical technicians, and 1 physician, and call that an interprofessional education intervention. We want to look more about how research can affect the true patient experience and perhaps put some thought behind creating new tools to measure that. And then again, measure behaviors in situ before we come to our conclusions. So I did go a few minutes over. I apologize, but I would like to take some questions. Thank you.